adenocarcinomas, they're defined by the fact that they've lost the drive from any thermostat in the body. They produce whatever they're going to produce regardless. So in your pancreas, and it doesn't have to be in the pancreas, 1/3 of them are outside the pancreas, 1/3 of them are malignant. The idea is you have too much gastrin because you have an adenoma hiding somewhere, pumping it out no matter what. I'm not eating, I haven't eaten, I'm not even looking at food, but I'm pumping out gastrin. So my acid secretion's high. So you get the second one in the middle, severe peptic ulcer disease. And that makes sense from the top one, gastric acid hypersecretion. So in people that you have them on PPIs, you move that prilosec, Nexium, Prevacid, Dexilant, no matter, move it up to BID, they still have gastritis. They still maybe on endoscopy have multiple ulcers. You got to start thinking, I've got their acid turned way down, at least the part I can turn down, and they're still producing ulcers. You better check a gastrin level. And if you get a gastrin level in these people, postprandially, meaning when gastrin should be low, natural thermostatic gastrin should be low. When I'm not hungry, it's after I've eaten, there's no reason to have acid in my stomach, and their gastrin level is 2.5, 3.5 times normal, you better scan them, because they've got a little BB hiding somewhere, and they may have zoledrilicis. And it's rare, but it's out there. Complications, now this is complications of the ulcer disease. Zoledrilicis is one of the ulcer disease-causing etiologies. Obviously hemorrhage. You don't want hemorrhage, especially in the elderly. Gastric hemorrhaging in the elderly usually is a fatal event. NSAIDs, obviously, NSAIDs cause this. Perforation is a bad event, that's free air. Not as common, but it is catastrophic. Gastric outlet obstruction. For people that eat a meal and say, 4 hours later, I'm bloated, I hurt, it won't go down, and they're not diabetic. Remember, diabetic gastroparesis causes this. But if they're non-diabetic, and every time they eat a meal, it stays in their stomach for a day, you need to find out why they have gastroparesis or if they have an outlet obstruction. And you can do a barium swallow and see that it looks a lot like pyloric stenosis. You better make sure they don't have an ulcer sitting right there in the distal stomach. Perforation, where do I have associated with non-steroidal anti-inflammatory use? Obviously, you got to get a rapid diagnosis. Endoscopy is the way to go. You can use non-operative management only if you don't go all the way through the serosal layer on the outside. You can have perforation with free air right in the outside layer of your stomach, but if you perforate, if you have free air, usually they like to do it and clamp that off. Hemorrhage, self-explanatory. All right, so key here, again, another yellow tidbit. How do you want to diagnose peptic ulcer disease? You need endoscopy. And we're talking about peptic, we're talking about the stomach. It's not talking about colon ulcers here. So you need endoscopy to really see what you have going on. And why is it so important to get endoscopy? Because you can go in there and you can do a culture for H. pylori while you're there, and you can take a little bite of the edge of that volcano that's sitting in there to see if that's gastric cancer. Because remember, rarely, but definitely happens, a gastric ulcer is gastric cancer. So you can do your biopsy, you can check for H. pylori. And those are both in yellow right there, notice that. So that may be a talks up again. Okay, so now we'll leave the acid, we'll leave the aggressive versus defensive factors and go into some other topics. These are pretty simple, pretty straightforward. All you need to know is on these slides, the idea of a hiatal hernia. And understand, your hiatum is that area of the diaphragm where your esophagus goes through and your stomach sits below it. A hernia, by definition, is any structure that moves into a position that's not where it was originally intended. So a hiatal hernia is obviously something that's herniating through the hiatum. Makes total sense. There are multiple types. There's type 1, 2, 3, and 4 of a hiatal hernia. You don't need to memorize that, but the idea is type 1 is simply you pulled part of the top of the stomach up. You just pulled that very, very proximal part of the stomach up. It is still just a bulb. That's that picture on the left. That's a type 1 hiatal hernia. Well, why is that important? Because the parietal cells, the acid-producing cells, are concentrated in that very proximal portion of the greater curvature of the stomach. So if I pull that portion up above the diaphragm, and that hiatum is still fairly tight, I've got technically an incarcerated type of a hernia that if it pinches off like a lower esophageal sphincter should, that is now a form of a strangulate, but that's not true. I'm just describing it. So in other words, you will produce your acid in that little bulb above the diaphragm, and it doesn't have anywhere to go. So I now have a trapped little balloon of acid that sits there above the diaphragm. These people have problems swallowing, they eat meals, and they say, oh, it's stuck here again. I don't know if it's achalasia or not, but over time it'll go through. But man, every time I'm hungry, these are the people that get hangry. My stomach hurts. This burns. Just looking at food or thinking about food, I burn right in the epigastrium, right above the xiphoid. I didn't used to do this. I don't know why this is occurring. And if you get into their history, and remember, you're doing this to take care of patients, you're in this position. So one of the great gifts that these patients give us is the truth of their life. So you get to do a history, and a history is something that when you all get out to clinicals, you'll think, oh gosh, a history is something I'm graded on. Don't look at it that way. These people you're talking to are total strangers. I'm digressing. They're total strangers, but it's a total gift that they're going to answer you truthfully about something as simple as your toenail fungus or about your wildest sexual experience. It's sometimes for STDs we need to know. But the idea is when they say, you know, if you get into their history, you'll find out, I never had this before I had rotavirus on the Carnival cruise 2 months ago. I vomited my guts up. I vomited for 7 straight days. I retched and vomited. And now every time I eat, God dang, it burns. Well, that is one of the causes of this. So you think, ooh, it started after a retching event. I better be thinking about hiatal hernia. So use the history to your advantage. That's, I mean, it's a great gift these people give us the truth. The one on the right there begins to be a type 2. And notice the difference. If you start to pull more of the cardia or fundus up there, you begin to put it paralaterally or parallel to the side of the distal esophagus because it can't go anywhere. So you make a lateral outpouching. The more you pull up there, that's the type 2, type 3, type 4. So what do we do about that? How does it cause? It's damage to the phrenoesophageal membrane, which is supposed to keep the stomach below. Type 1, only the GE junction is pulled up, that little bubble we saw a minute ago. Type 2, 3, and 4 depends on how much other stomach you pull up there. 95% are type 1. And you think, well, golly, if any of you all have ever worked with a GI doc, you say almost everyone we saw was a giant hiatal hernia. That would be a 3 or a 4. That's because the type 1s don't typically come to the doctor. They just say, oh, I just don't feel right after I eat. I'll deal with it. I'll take Prilosec and move on. You just know the majority are type 1. Prevalence in North America, 10 to 90%. Look at that range. You can't be asked a question. That's you know, 0 to 100. What is that? Okay, so, and you got to think about that when you're looking at test questions and boards. If you've got something that's got a prevalence of 16.375%, you might see that. If you've got a range of 10 to 100, that means we don't know. There's other factors involved here, so you know, use statistics to your advantage. So hiatal hernia, trauma to the phrenoesophageal membrane, obviously. You lose your lower esophageal function. Sometimes that whole thing gets pulled up there. So all this peristaltic stuff, you get terrible distal esophageal gastritis and burning, lots of problems there. You trap the parietal cells up there, you get erosions, you get too much acid, symptoms, burning, dysphagia, occasional regurgitation, high risk for peptic ulcer disease within the hernia itself. So if you pull a lot of the stomach up there, you hold acid, eventually you're going to erode through the wall of the stomach. So those people, type 3 and 4, you might need to do something about that. And that's something. Type 1. Okay, so diagnosis, EGD is the gold standard again. PPIs you need to use to control ulcers. Notice that's yellow. And then the surgical repair. That is reserved for type 3 and 4, and you need to have a secondary complication like severe gastritis, a known ulcer, or a volvulus being a twist. Because remember, your stomach squeezes, it ruminates. So you pull a bag of your stomach up, you stick it in your chest, you move, you know, part of the left lower lobe of the lung over, because it fills with gas, now you've got a softball up there, and then it begins to squeeze and twist. It can wrap itself around the esophagus and make a complete obstruction. So for that, you need to do something. The surgery is called the Nissen fundoplication. Brutal surgery 15 years ago, chest and belly, took a CT surgeon and a general surgeon. These people ended up in the unit for a week or more. It was terrible. And then we got good with the laparoscope. They now do laparoscopic Nissens, where they actually go in the mediastinum, put 2 trocars into the abdomen, and the 2 guys can work together, pull the stomach back down, rebuild the hiatum, make sure you're not doing anything in the mediastinum. Hopefully you don't get infected. These people do fairly well. They do fairly well. I've seen one Heredoma, it's not good, but you don't have much of a choice in some cases if you have risk of perforation, so you're kind of behind the 8 ball on occasion. But Nissen fundoplication is the main surgery for type 3 and 4 hiatal hernia. Pylotic stenosis. So pylotic stenosis is one of those topics, I think it's the last one, but the idea is if you understand it mechanically, you understand it physiologically, you'll get whatever questions, and you also will not miss it in pediatrics, because I'm a little bit surprised at some of the PAs that are out there that have never heard of pyloric stenosis and they're doing pediatrics. So understand this, it's very simple, it's very straightforward, but this is pyloric stenosis. So it's also called infantile hypertrophic pyloric stenosis, just a description. 2 to 3.5 per 1,000 live births, males over females, who knows why. Etiology, unknown, meaning what do we do that causes this? What happens that causes, we don't know the etiology or we fix it. It has an association, strangely, statistically, with kids who've gotten a macrolide before 2 weeks. And if you remember, we used to use erythromycin paste, erythromycin gel in the eyes. We used to use for kids that we worried about meconium aspiration. We would use gentamicin, we'd use high doses of erythromycin in the hospital. Well, that was great. And then somebody came up with this association, so they stopped using the macrolides, and the incidence actually dropped a little bit. We don't know why. We do know that erythromycin was actually invented as a pro-motility agent. All erythromycins, including Zithromax and clarithromycin, make your GI tract squeeze. So when you use those medicines, this is digressing, when you use those medicines, tell people it's going to possibly upset your stomach, take with food, may cause diarrhea. Not because you're allergic, because half the people out there that have Zithromax and Biaxin as an allergy, they're not allergic. It's doing what it used to do. It's a pro-motility agent, and they were getting that side effect, but nobody ever told them. So tell them, and they'll say, oh yeah, I was told about that, no big deal. Anyway, that may have had something to do with it. But the pylorus right there, if you see, the distal stomach should have an open lumen to it. It shouldn't look anything different than the lower esophageal sphincter, which is a muscular ring that contracts. But for some reason, the muscular part of it hypertrophies. And it hypertrophies only in that segment. So you shut the lumen. It doesn't get any larger on the outside until late, but it shuts the lumen of the stomach, so you have a complete gastric outlet obstruction. And remember, the younger you are, the more effective and active all your tissues are. Your muscles are, smooth muscles are, everything is. So if you feed a baby, and within 10 to 15 minutes, he fires the breast milk or the formula across the room, the stomach is saying, something's not right, I can't move it forward. It is ruminating, and the esophagus is like a tiny little squirt gun, so you get really good pressure gradient, which means you can projectile vomit. So the problem is, if mom says, every time I breastfeed, my baby hates my breast milk, it throws it up all the way over my shoulder and into the wall, my baby hates me. And I've heard that. They say, no, feel them on the edge of the rectus, you'll feel the olive in there. I'll show you what that is in a minute. But anyway, that's pyloric stenosis. Clinically presentation, projectile vomit, ages 3 to 6 weeks is the usual time. Reason being, it takes that long for it to really hypertrophy, and then the kids start losing weight. Sometimes the mom will allow the kid to throw up for a month. The problem is the kids lose weight. They just start dropping weight, and that's dangerous. Kids, you can't let them lose weight. And so when mom finally brings it in and says, I don't know what I'm doing, they hate me, and you find out. You palpate their abdomen, you feel right on the right paramidline area, not the right upper quadrant, right in the paramidline area where you would have a diastasis recti, and you'll feel that in there, you'll feel kind of a golf ball. That's what it feels like. The kids are emaciated, they're clinically dehydrated. They commonly will get a hypochloremic metabolic alkalosis. Now, I don't know if you all have done lab medicine yet. Have you all gotten into that yet? Okay, cool. So have you all done renal physiology? Excellent. Great programs. You guys, so lucky. I'm not kidding. You guys have no idea how lucky you are. But in renal physiology, if you remember, if you have an acute acid loss, your body does not like acid-base imbalances, hates it. And so in order to try and recapture that, your distal tubules in your kidneys say, I need to hold on to every bit of acid that we're peeing out. And I'm willing to trade it for anything. I will trade for anything. So the first one to go is going to be chloride. I'm going to send out a chloride and grab onto a hydrogen ion. And so you get hypochloremic metabolic alkalosis. You don't have that much acid in your pee. because the poor kiddo is dumping all their acid out. But the bottom line is, that's another hint that they have pyloric stenosis or some gastric outlet syndrome. And the problem with that is not that you have to memorize that part, but the idea is you don't want to operate on a kid who's either acidotic or alkaline. You have to correct the acid-base imbalances first. And that's in anything. That's in somebody with small bowel obstruction, that's in somebody with cholera, that's in somebody, anything that throws acid-base balance off, more than just a little bit. If you anesthetize them, they go into cardiac standstill. You get into real problems. So you say, okay, I'm going to give this kid IV hydration. They'll do fine with D5. They'll get some energy out of that, but I'm going to take some time and get their electrolytes back in balance, bring their pH back down in range. Then you can go in, and that just takes a day. Then you can go in and fix this. So it is a surgical sub-emergency, but the real emergent thing is get them electrolytically fixed, then you can go in and fix this. How do you want to diagnose it? Abdominal ultrasound is still the gold standard, very sensitive, very specific. You have to have the right ultrasound machine, and you have to have the right person reading it. And in some rural areas, we don't have either of those. So they want to do barium swallows in a baby. You want to do that to a kid who's really alkaline. They want to do MRIs of the abdomen, because a lot of these places have a big semi-truck that comes in every Tuesday, backs up to the ER, no kidding, backs up to the ER, and they can roll anything they want into that truck, and you don't want to MRI baby on this. You don't do that. So, abdominal ultrasound, the idea is transport them to the center that has it. You can do an upper GI series, I'm not sure that's necessary. Bottom, and obviously we just talked about. So these are different figurative drawings of pyloric stenosis. So the drawing there on the left is actually really, really old from that same gentleman, Schwartz. So this has been known for a while. Barium swallow there at the bottom. Notice that thin little neck where the fluid really can't get out. That's the pylorus. But you don't really have to do that to a poor kid. Notice they have to drop a tube into the belly to fill it with barium. Little kiddos are not going to drink barium. They're just not going to do it. So you've got to put a tube in a baby. You don't want to do that to a newborn. The best way to do is the upper right picture. That is the ultrasound. That's a great, and now the sensitivity of ultrasounds is color. I mean, it's so much better than that. It looks 3D now. But the idea is you see that thickened pylorus there. Both sides of it are thickened. Nothing is getting out of that stomach. You say, okay, the kid has the right signs. He has the right symptoms. He's metabolically deranged. And we got an ultrasound. This is pyloric stenosis. So what is the treatment? Pylorotomy. Ramstedt pylorotomy is the way to do it, also called the Heller pylorotomy. And it's kind of neat how they do it. You take this oval walnut, you open it longitudinally. I've done this surgery sometimes. Open it longitudinally, and you sew it transverse, and you're done. So it takes your elongated oval and makes it short and fat, but it opens up the lumen. Strangely, that muscularis area, that hypertrophy, does not continue to thicken. Doesn't do it. Otherwise, you'd think it would just continue to grow. You'd have this giant thing. No, it doesn't continue to thicken. Again, you correct the electrolyte abnormalities first. You do your pylorotomy, longitudinal incision. You close it transverse. You can do it open or laparoscopically. And now, doing it laparoscopically to a 6-week-old baby, these kids, they go home the next morning without problem. Okay, so the other treatments, and I read a write-up about this. Balloon dilation, now think about it. If you go in there and mechanically balloon dilate the kid's pylorus, are you fixing the problem? You are not. It's going to close in 4 hours, so not a very good choice. They tried for a while atropine injections. We're just going to load this dude, block parasympathetic tone, and this will dilate, this will fix it. Well, it dilated while you had the needle in there giving it the atropine. Atropine has some other effects in the body. You all have done pharmacology and realize in ACLS. Are y'all doing ACLS yet? Okay, you'll do it. But atropine raises heart rate. Babies are usually already tachycardic and hypovolemic, so you take a baby with a heart rate of 160 and give them atropine. Trouble. And then the last thing is conservative management. You see my statement there, watchful waiting is what we call conservative management. Works in a lot of things, not this. So have a strong malpractice insurance and a backup employment plan. You'll be the license will be taken away. But the idea is you need to treat the problem. Don't just kind of band-aid it. And if you understand it mechanically, you all will not memorize anything about pyloric stenosis because you now understand it mechanically and you can think, well, that's not going to work. Somebody wanted to come in and say, well, let's just jab with atropine. It's just not going to work. And And that should be in the series one. No, here's the pylorotomy. You see that on the left, the longitudinal incision, and then the transverse sewing, the sagittal sewing. It just foreshortens that little pylorus and works like a charm. The one on the right, if the pylorus is very long, you can actually do what's called modified Nissen, which is what we do in gastric bypass, but you actually fold it down and sew it to the distal stomach, so you have a very wide open exit. And these kids, I mean, they have a little bit of bowel trouble, but you don't want to make that exit to the stomach very wide open, because you need to mix things with acid and turn them into kind of a liquid paste before you send them downstream. Okay, so there's the end of it. Do y'all have any questions? And you're out half an hour early at least. All right, very good. Thank you guys.